Hi, my name is Hannah McLaughlin, and I am a third-year resident at the University of Utah. On behalf of my co-authors, we are excited to present our project entitled Accessing Gynecologic Oncology Care, a comparison of rural and urban gynecologic cancer patients. I have no disclosures to report. The Huntsman Cancer Institute is an NCI-designated comprehensive cancer center serving 5 states and the largest geographical area of any NCI center, which comprises 17% of the U.S. landmass. Rural gynecologic cancer survivors have higher death rates than urban counterparts, particularly for cancers that are preventable through screening such as cervix cancer. Unfortunately, few studies exist specifically evaluating rural gynecologic cancer patients. Barriers to care may include distance to care, transportation difficulties, poverty, and lack of specialty providers in close proximity. Our objective was to compare the time to diagnosis, referral to gynecologic oncology, and first treatment for rural versus urban gynecologic oncology patients in the Mountain West. We conducted a retrospective study of rural and urban gynecologic oncology patients who were seen at Huntsman Cancer Institute for first consultation between 2019 and 2021. The Rural-Urban Commuting Area Codes, or RUCA codes, were used to classify patients with a RUCA score greater than or equal to 4 as rural and those with a RUCA score of less than 4 as urban. We collected demographics and time points related to symptom onset, diagnosis, referral, and treatment via chart abstraction. Time points are reported as medians, with 95% confidence intervals and Kaplan-Meier curves. Curves were compared with log-rank tests if proportional. Where proportionality was violated, a Wilcoxon test is reported. Of the 74 patients included, 27, or 36.5%, were considered rural. Rural patients lived, on average, 141 miles from the cancer center versus 37 miles for urban patients. Demographic factors shown in Table 1 were similar between the two groups, though rural patients were more likely to have a household income of greater than $75,000 and were more likely to have a benign or precancerous diagnosis. The distribution of cancer types were similar between the two groups. Figure 1 shows the Kaplan-Meier curves for certain time intervals, stratified in days, between rural versus urban patients. The medians of each specific interval are shown in Table 2. Rural patients were diagnosed sooner after their first visit, but referral to gynecologic oncology was longer. The time from symptom onset to first treatment and from first visit to first treatment were similar between the groups. In this small cohort, the time to diagnosis and referral to gynecologic oncology differed between rural and urban gynecologic oncology patients, but their time from symptom onset to first treatment and from first visit to first treatment were similar. Further research is needed to better understand the underlying factors causing the disparities between rural and urban gynecologic oncology patients, to then develop targeted interventions to address these disparities and improve access to care. Thank you for tuning in to view this abstract. I would be happy to answer any questions or comments pertaining to this abstract via email or the YouTube chat.